I will not give a complicated talk. I will make sure you have 3 take-home messages: how to treat G12C mutated colon cancer, MSI-H, and HER2 positive. That's all you need to take home because you can implement it in your clinic tomorrow. Now, it's Colon Cancer Awareness Month, so I want to make sure all your patients and their families get colonoscopies at age 45. It's the most preventable disease, not breast and not uterine, okay? So you can prevent it. Colon cancer has undergone an incredible molecular classification. You can see here all the mutations which have potential actionable treatments. And for some of them, I will highlight. Now, this also means we are not doing germline testing. Okay, so please make sure that in addition to your NGS testing, you consider germline testing for everyone who is at age 50 or younger or has a family history. It will help to potentially prioritize treatments not only for immunotherapy, but also prioritization in later lines of treatment. When you have, for example, an AT mutation, then I would do TAS102 and not REGO. So it has implication. Now, I know that colon cancer came after breast and came after GU. That is a mistake, because colon is the most important organ, at least according to the German psychiatrists, who divided life in 3 parts. The first part of life is all about love. The baby loves the mom. The teenager has the first love. The second part of life is all about sex. And we all know about that one. And the third part of your life is all about your bowel movement. So you will all be affected by it. So you cannot get around the colon. Now, looking at this, you can be very proud that we have done a lot of progress in certain identification of mutations. But actually, there is something very important missing. The next frontier of new drug developments and changing outcome is not listed here, because these are targets in the tumor microenvironment and not the tumor. So you will see in the future really a better understanding how the environment, the endothelial cells, the nerve cells, the immune cell trafficking, the cancer-associated fibroblasts will play the most significant role in order that our treatments targeting the tumor will be successful or not. No doubt in my mind, the targets in the tumor microenvironment will change the outcome in colorectal cancer to come. Now, what is colon cancer so unique? Because it's one of the most heterogeneous cancers we have. This is the 405 freeway, and we all have seen it, and we all have unfortunately experienced it. Why do I show that? Because this is not colon cancer. This is a GIST. It has one pathological ongoing activated pathway. When you use an inhibitor of the c-KIT mutation, you have a stop and you have success. There are very few examples. Now, colon cancer may fit in a little bit when you have a HER2 amplification. I'll show you why. Because this is the driving oncogenic pathway. But colon cancer looks like this. This is the subway of Tokyo. Because there are a lot of redundancy of signal transduction in a colon cancer cell. That makes and explains that no single agent drug is effective in colon cancer, because even when you go to the major intersection and you block it, you find a way around it. And that's exactly what colon cancer cells do. When you look at BRAF inhibitors and G12C inhibitors in non-small cell lung cancer or in melanoma, you have single agent activity of 20–30%. In colon cancer, it's 5 to 10. It does not work. We always need combination treatment. And that also reflects how these tumors overcome the inhibition of a major intersection. The molecular escape mechanism of colon cancer is 10 times more than any non-small cell lung cancer can do with the same inhibitor. It's more complex. We need to be smarter to develop treatments. So I give you some examples which you can use in your clinics in the clinical outcome and treatment strategies. We are hearing a lot about G12C. Now, I think what is often not known is that the G12C mutation is different than the other KRAS mutation, even in the same codon. Much poorer outcome, much more chemoresistance, for example, to a G12D. It's a poor prognostic marker. So when you see a G12C, you need to potentially consider the most aggressive treatment regimens. Be aware of it is a highly prognostic marker. I will show you some clinical trials and data, and these data are now integrated in the NCC guidelines. You can order it, and it will be covered by your carrier. Even not FDA approved, but the insurances usually take the NCC guidelines. And you can see here, and I don't show the single agent data because they didn't work. This is sotorasib with panitumumab, different doses. And you can see there is a significant benefit with a higher dose of combination treatment. And the PFS for 5.6 months is not bad. In fact, that's almost the PFS of second-line FOLFIRI-BEV for metastatic colon cancer. Now, this is very important. The response rate here are about 26%. This is very respectable because in second-line FOLFIRI-BEV, we have 10 to 15%. So we have a significant anti-tumor response. The problem is the PFS is 5.6 months. It's not bad, but it does not last. And we have very similar data from adagrasib here in combination with cetuximab. And you can see we need the EGF receptor blockage in order to have the G12C inhibitor being effective. You need a second hit in the signaling pathway. There are other combinations in development, such as the SHP2, the SOS1 combination. We will hear so much more in the future about it because I don't think the EGF receptor inhibitor combination is the last thing we see. And you can see here with adagrasib and cetuximab, your response rate go to 40%. That is amazing. So you need to be aware of that you have a treatment option for G12C, which is now being recommended by national guidelines. Now, there are a lot of new kits on the block. Here is divarasib, and you can see similar efficacy. A lot of response rate of 20, 30, 40%. This is here single agent. Here, the duration of response is very good with 7 months, but the PFS sticks between 5 and 6 months. Now, this is something very important. This is the data of sotorasib in combination with chemo. And my first reaction to this kind of clinical trial is boring, or do you have no better ideas to combine sotorasib with chemo? But the data are amazing, because it has probably higher efficacy. How is that possible when the cetuximab G12C inhibitor combination looks so and sounds so sexy? Because the molecular escape is completely different. Tumors cannot escape as much with the chemo and sotorasib compared to the cetuximab combination. Very important. So I think we have not seen the end of the combination treatments. It's actually biologically extremely exciting because when you have this very specific inhibitors, the tumor can find around it. For chemo, there is no around it. It's all the cells and not selective for certain activated pathways. So it may sometimes be beneficial to have the chemo as a partner. So my take-home messages is the G12C is very prognostically poor, more resistance to chemo. It's only 3% of patients, but you have now data on the combination with anti-EGF receptor showing response rate from 20 to 40%, PFS from 5 to 6 months. I think that we have not seen the end of the combination, and the combination with chemo look extremely promising. I'm sure that you have seen the Dear Doctor letter from adagrasib, from Mirati, with significant skin toxicity. You need to watch out and be aware of it. And here you see it is integrated in the NCC guidelines, so your insurance carrier should not give you a hard time to approve it. So what is new on HER2? And it's, again, a completely different story than in breast. Forget the breast data, look at colon data. When we have a HER2 activation, you can see when we block it, and it almost doesn't matter how. You can see all the different trials with small molecules and antibodies and different antibodies and the antibody conjugate. You see response rate between 20 and 50%. When you hit really an oncogenic driving pathway, you see the response. You can see a little bit differences in the PFS and the overall survival, and the bluely high-marked are the best ones and the most recent ones. In the Mountaineer trials with the small molecule tucatinib, you see a PFS of 8 months and a survival of 2 years. That is amazing, and that is the reason it was approved. And then you see the Destiny trial with the TDXD, the PFS a little bit shorter, 7 months, and the survival is 15 months. So when do we use the Destiny cohort or the Mountaineer cohort? So Dr. Vergaaf presented at ASCO last year in HER2 overexpressing or amplified HER2. And this is the most important slide. We already know the PFS and overall survival. And the most important slide is not the waterfall, it's the orange triangles. Because for the TDXD, you don't need to be wild-type RAS. A very important distinction, because half of them are. So tucatinib, it has to be wild-type, but for this, you don't. And you can use the TDX after the tucatinib trastuzumab treatment fails. Now, there are more little bit subtle differences, and I will get back to it. The Mountaineer data are probably the most promising because of the long PFS and overall survival, and you can see the significant waterfall plot and activity of tucatinib trastuzumab. This is the one who had 2-year survival in refractory patients. You can prescribe it tomorrow. Tucatinib for wild-type trastuzumab, and when it fails, go to the TDXD. And these are the survival data, just to tell you that this is a highly effective treatment. So a couple of things I want you to take home. There are significant response rate with tucatinib and trastuzumab, and it seems to be the case for HER2, 2+ and 3+ and amplified. For the TDX, in contrast to the breast, we need at least a 3+ to have efficacy. So you give a little bit of difference in the activity of it. Now, mentioned again, you need wild-type RAS for the TT combination. Now, there is the second point is may exclude EGF receptor for HER2 overexpressing. That is absolutely wrong. Our paper came out yesterday in JCO showing that high expression of HER2 is actually an indicator for sensitivity to cetuximab. So it will change a little bit our understanding of HER2. So look it up tomorrow. It's online. I'm going to finish up with IO treatment in MSI-H. This was presented at ASCO GI a couple of months ago, showing the first-line treatment. Remember, we published the data on nivo-ipi in first line with phase 2, with response rate of 70 to 80%, and PFS at 2 years, 70%, and overall survival, 80%. It's like unbelievable. We don't have any median reached. There was always a criticism because how can we know that nivo alone or pembro alone is not as effective as the combination? So this is randomized nivo versus nivo-ipi versus chemo. Now this is the first update, but the median of the nivo is of course not reached either, but the chemotherapy is reached. And these are the data. We don't see that so often in GI cancer, a hazard ratio of 0.2. Now, there is something very interesting, and many of you probably remember the Keynote 177. The hazard ratio was 0.4 or 0.5. And in the survival curve, in the first 6 months, the chemo was better than the pembrolizumab. And everybody was freaking out and thinking, how is that possible? Well, you see, there is no crossing here. So what was the explanation for the Keynote 177 crossover? It was misclassification of microsatellite instability. 10% were misclassified, and in these, the chemo worked better, which makes sense, okay? Because they were actually MSS, and the immuno does not work. So you need to be very careful because the local labs were accepted and some of them were not done correctly. Now, there is always this myth that IPI is more toxic. And it's true depending on the dosing schedule. If you use IPI 1 milligram per kilogram every 6 weeks, you do not have any more side effects compared to Nivo alone. It is absolutely in our clinic, we only use Nivo IPI for MSI-H tumors. Now the CTLA-4 is gaining also significant more ground on MSS, and I will show you some data on that. But CTLA-4 is part of a very effective immunocombination without increasing toxicity if you use the dose regimen I just told you. So I want to talk a little bit about MSS because that's the biggest kind of interest of research field in colorectal cancer. And we are often making the mistake when one drug doesn't work, like Nivo or IPI, we say this class will not work of drugs. And that's wrong. We actually have learned many times that when we optimize the interaction of the target, we see some success. And that's exactly what happened for the Fc-engineered CTLA-4 antibody by Agenus. Now, interesting, they're actually Fc-engineered, so the interaction with the antigen-presenting cells is optimized. And something very unique, they put a mutation in it. And because of this mutation, you don't have a complement activation, which means you don't get hypophysitis. Okay? And the data were amazing. MSS, refractory colon cancer, had response rate over 20%. Now, when we exclude the liver metastases, the response rate is over 40%. And a registration trial finished in record time and is now waiting for the analysis to get this combination approved. Now, when we look at the outcome and survival, we remind you, metastatic MSS refractory colon cancer, this is the median survival is not even reached in the patients who have extrahepatic disease. There will be a new treatment option, and it changes a little bit the way we also indicate local regional treatment for SBRT or surgery of liver mets to make them disease-free of the liver to have potential additional treatment options. Now, it doesn't mean this combination does not work at all in the liver. You just don't see the same response rate. There is some stabilization of disease and a little bit shrinkage, but not reaching PR. So it's not you're harming them with liver lesions. Now, there are also some data. This is from Dr. Fakih from City of Hope, combining Nivo IPI. And here the IPI is the important addition to it because Rego-Nivo does not work, or Rego-Pempo does not work. You can see again, interesting survival benefit when you combine a CTLA-4 for no liver metastatic patients. So this is important to know. There will be more coming, particularly with the BOT/BAL combination. And BOT/BAL is moving to first line, and the data in MSS are amazing. So I'm going to finish here. This is my crazy lab. I wanted to let you know that we are working on the TME. I think I told you in previous meetings, we identified completely novel targets in the tumor microenvironment. I told you that, for example, Parkinson's patients don't get colon cancer. We know why. It's all the neurotransmitter. Peristaltic in the colon makes a lot of sense. We know that Down syndrome patients don't develop cancer. We know exactly why, because DSCR1 is the most important inhibitor of NFAT and VEGF receptor 2. These patients have in situ but not invasive cancers. So, and we are working on the circadian clock. People who work at night shift develop more colon cancer. We have compounds for changing the clock with significant increased efficacy of immunotherapy and anti-VEGF treatments. All preclinical compounds are already available, so we're going to move forward into the clinic very soon. And I think our goal is the right treatment at the right time. Make sure you get an NGS testing. Make sure you get a germline testing. Liquid biopsy, we mentioned, a big goal in colon cancer, a big issue for MRD, but also for metastatic disease to identify novel actionable mutations at resistant situations, and then, of course, accelerating the clinical trials. And there is no doubt, and we have already integrated AI, we found novel markers, which are amazing. I always end with a German philosopher, Immanuel Kant, the one who knows more may decide better. Thank you very much.